Welcome, everybody. Hello out there in DSN land. Thank you guys so much for joining us for today's webinar. This webinar is all about integrating frenectomies into a general dental practice. And today's presenters are none other than Dr. Michael Dienberg, who is a hospital trained general dentist specializing in CO2 laser tongue and oh my gosh, tongue. This is a tongue tie itself. Tongue and lip tie releases for patients of all ages. With more than a decade of hospital-based surgical experience, he has performed or supervised thousands of releases and also provides IV moderate sedation, complex extractions, and comprehensive dental care. He currently serves as clinical assistant professor at Oregon Health and Sciences University and practices throughout Oregon and Washington. Bethany Dienberg is also joining us today, and she helps keep frenectomy and surgical days running smoothly at Otter Oral Care, combining her background in exercise science with chairside assisting, patient coaching, and practice operations. She's supported hundreds of laser releases and wisdom tooth procedures and especially enjoys helping postpartum families navigate feeding milestones. Outside of the office, Bethany enjoys skiing Mount Hood, exploring the Columbia River Gorge, and spending time outdoors with Michael and their three kids. Welcome to the podcast or slash webinar, guys. How are you today?
Fantastic. How are you?
Great.
Oh gosh, I'm very, very excited to dig into this. I've seen you guys in action at the Colorado Surgical Institute, both with wisdom teeth and when you guys were doing frenectomies during that beta course. And it is really, really impressive how quickly and efficiently you guys are able to do that. So I'm gonna let you guys take it, and I'm gonna be the peanut gallery over here from a general dentist standpoint that's only done these a handful of times with the old fashioned non CO2 laser and never even came close to being able to be efficient enough to be able to integrate this into a general dental office. So I'm going to let you guys take it away, and you have a nice presentation. We can talk all the way through this, but the whole goal here is kind of helping people envision and get some practical and tactical advice on how you can take this surgical procedure with a current patient base that you're seeing and create uh, another stream of income and service the patient base that you currently have in the best manner possible. So take it away, guys.
All right. Absolutely.
It's just a matter of getting this up
We're
there.
going to get this set.
All right.
All right. Can everyone see that?
Yes.
All right.
Fantastico.
All right. Looks great.
I'm Michael Dienberg. This is Bethany Dienberg. And so we're part of Colorado Surgical Institute. We teach there. And then, we have a course coming up in September. So what we're going to cover today is the why, what, and how of frenectomies, frenuloplasties, frenotomies. Lots of words. We'll kind of dive into a few things here, and then how you can integrate it into your practice. Why frenectomies? I mean, this is a pretty obvious case, an undiagnosed epidemic. I think, how many patients do you diagnose in your current practice? General dental, we weren't trained, at least I wasn't. I went to Marquette. We weren't trained how to diagnose tongue ties.
Mm-hmm.
We're coming at this from a standpoint of being in lecture and in oral path and learning about Hattie tongue, which is one of the diagnoses that one of the instructors said it like that, and then looking at a slide of tongue tie and realizing that I was tongue tied, and so I had
Who was your pathology professor? I went to Marquette as well.
I want to say Sadehi, but I don't know.
Same guy. I had him too.
Hattie tongue.
Yes. Yep.
Like
That's why I was laughing because I remember his accent vividly.
So that was seared in my brain, and then basically bringing it up to an upperclassman saying, "Hey, I think I'm tongue tied," and then we got in with one of the oral surgeons, and he's like, "Yeah." So we did the old tent technique with scissors and stuff, and so I got some relief from that. I had to revise a little bit, but that's kind of how it started for me. And then, how much, like beyond that, we really didn't learn about it. We learned about the lateral border of the tongue specifically, right?
Mm-hmm.
and how to diagnose oral cancer, which we don't often see. Even when I would be in the hospital, I would see a ton of that stuff, but I wasn't actually firsthand diagnosing it. It was like the after effect of this is a suspicious lesion and the referral off to the oral surgeon. And I would take out teeth or whatever. And then, they would remove, complete glossectomy. The last time I was in the OR on one patient, right? So anyway, we're not looking at the tongue. We're not looking at the frenum under the tongue. We're not looking at, airway and all that type of stuff, at least in dental school. So it takes getting out of that. And really, I mean, we have the gateway to looking at all these things routinely and incorporating into the practice. So one of the missions of all of this is basically to allow general dentists to start looking at the tongue and having a criteria that they a workflow to go through very quickly in the periodic exam and then the comp exam, so that they can funnel it to the right place, and hopefully it's to themselves, basically. Not that every patient's going to have it, but yeah. Let's see here. Who needs the procedure? Well, infants, newborns, breastfeeding struggles, poor latch, right? Moms, it's a dyad between the infant and the newborn. And then
The infant and the mom.
Or infant and the mom. And then children, right? Children have speech delays, orthodontic concerns, and airway. It's a great time to catch this before moving on to other growth and development problems that stem from ankylosing or tongue tie, right? And then adults, right? Myofunctional patterns, jaw tension, unresolved symptoms. We have a patient today that we're seeing that tension can't get relief from chiropractic work, from body work, from whatever you name it. And he gets like relief for 2 weeks, and then it all goes back to just super tense, and then knows he's tongue tied. And so we'll see him later today, but I've heard that story so many times. And then orthodontic patients, right? We have some cases that we get referred to our office that some orthodontists like to do this ahead of time. Like at Marquette, actually at ortho, and that was included in my treatment plan, is to get the lip taken care of because I had a diastema between 8 and 9. And you have some specialists that don't necessarily think it's that important, and then they get relapse. 8 and 9 open back up into the diastema after ortho, and then happy parents, like some of our parents. So
I'll just add to this too. A big area of focus right now that's kind of coming into play a lot is sleep. And we do have more and more supporting research for children and support of like mouth breathing and sleep apnea and resolution in that space, but also adults who might be, hey, like they're telling me I got to go on CPAP. So that's also an area of opportunity, is like maybe like we can start in this area and kind of grow from there.
Yes. And that's kind of our gateway into communicating with the pediatricians, the PCPs, because they just think this is a moneymaker business, period. Like some of them, not all of them, but some of them don't believe in it. And it's through and through, infant to adults. And so, anywho, so why frenectomies belong in your practice. So this is us, basically me teaching. You guys are doing the hands-on. That's the big thing with this course is, or within our course, is that you guys are doing the surgery. I'm there to help. I jumped in. I think this was the demo patient, but you guys are doing the surgery. There's no other place like that for the lingual frenectomy and maxillary and buccal and all that, but you guys are doing the surgeries. So it's GPs teaching GP. I'm a GP with lots of hospital and surgery experience, but I love to share.
And you're, as dentists already, you're doing these exams, you're able to see when Michael's in clinic, he sees tongue ties on repeat with patients. Once you know what you're looking for, if you're already doing those exams, it's going to be just a lot. And we're seeing it. We still don't know the full reason why, but it is really common in across age population that you'll come across those tongue ties as you're start assessing for them.
Yeah, once you have that filter, it's like you can't unsee it. And I come at it as objectively as I can. Like, I don't want to find the tongue tie now, and I'm seeing it, and it's like, yeah, that's a tongue tie. You know, do they want to do the surgery or not? That's another question. But
Are there questions for people that are not adolescent and infant? Are there questions that you ask them once you identify it? Like, are you having trouble with XYZ that kind of furthers the conversation?
absolutely, we have a symptoms list. We're not going to treat it unless it's symptomatic for the most part, right? And
Okay.
even if it's to the tip of the tongue, there are people that functionally are perfect. They have no restriction because
Mhm.
the middle part of that type of tongue tie to the tip, the middle part may or may not be able to get up where it needs to go and function just fine.
Sure.
So the symptoms kind of drive. So yeah, they might think they have a tongue tie. We give them the intake assessment, and then they start checking boxes, and that's where we glean a ton of information. And I can say that we haven't had anyone referred to us specifically that hasn't had symptoms of
Yeah.
some sort.
Mhm.
But like your like adult population, like one of them is like if they're really tied, they might not be able to fully clean their teeth, so you're going to have some issues with dental caries. When you're also looking into like just their regular medical history, like did they have issues eating growing up?
Picky eating.
Yeah, a lot of like just
Speech language.
oral dysfunction in terms of like how they're able to move food around in their mouth, how they're able to speak. We see a lot of stuff with like kind of therapeutically. Are they tight? Do they have migraines? We see some correlation with TMJ. We see a lot of correlation with palatal expansion and what type of orthodontic work did they have growing up. We see issues with breathing and exercise and activity. So it honestly can check a lot of boxes, and it is multifaceted. So typically once you're getting into this older, like past the age of 12, now you're starting to deal with more long-term issues. So a lot of coordinated care is coming into play, and it can expand from that, or you kind of at least can focus on getting that release and getting them some immediate relief on the front end as well.
Cool.
Yes.
Great.
Right. So the interdisciplinary opportunity that it provides is honestly abundant, because once you start getting integrated with different folks, then you become the it person in your area to address this in whatever fashion. Or maybe you don't want to, you just want to know more about it so you can refer out to that person. But if you want to become the person, that's a really good thing. And IBCLC, so basically lactation specialists, speech language pathologists. Now, I worked with all these teams in the hospital, on cleft and craniofacial team, but to do it outside of that is a little unique. And so midwives, I don't know how many of you, if anyone on here is a specialist in like we had a couple pediatric dentists in our last course. So it just provides that opportunity to really communicate with them.
I think like one of the biggest things of bringing this into a dental office is really being open to more collaborative like work, and y'all are already doing that, but like really like finding some spaces. Oral myofunctional therapy, I also see as a really big opportunity with your hygiene and or assistance as an area for them to grow into and keep that in-house. And you can offer pre and post frenectomy like discount, like groupings, or like, hey, buy this many, we'll work with you. And then this also allows them just some additional interest of like, maybe it's not as monotonous, and now you're doing some different care and you're keeping that all in-house is a really, really great area of opportunity in one aspect. But really being open to coordinated care, because what you'll start to find in this space is there's so many more things going on with the oral function of the tongue, even the lip. And so having that ability to translate that across the board. And so when we're working with babies, we have a really specific, unique set of people we're working with. When we're working with toddlers and kids, it might be speech and language, oral myofunctional therapy. You also might be working with occupational and physical therapists as well, chiropractors. And then as you get older, there might be sleep dentistry. Again, a lot of body work, a lot of oral functional work. And so this is actually like your, to get traffic in and out and kind of have that workforce within the space. And then if you really want to keep it foolproof, bringing oral myofunctional therapy into your office is really going to help assist in that space as well.
And a lot of your hygienists might be already interested, but if you don't know how to diagnose it, I've seen that dynamic of where they're kind of hesitant to even bring it up. And if they do bring it up, they kind of get shut down. And they're very fascinated by it because they see it all the time. And, certain patients bring that out in them. And so it's an opportunity to explore that, whether you proceed with it or not. But anything else?
Yeah.
All right. So what is a frenectomy? Frenectomy, frenulectomy, lots of different words. So basically excise, right? A surgical procedure in which you completely remove the frenum or frenulum, including the attachments and underlying. I wouldn't say bone. That's actually shouldn't be in there. But this may involve cutting, excising, or using a laser to eliminate the frenum. I guess bone meaning like on the tongue specifically. On the lip, absolutely. Get down with that.
And also just inserting to the fact that there is the terminology frenectomy, which is more of that incision of the tissue, which is typical of like a scissor release in infants. We typically see, or we'll even refer to it as a frenectomy, mostly with baby population that we're working with.
Insurances have a wonderful way of kind of
navigating that.
Each having their own definition. With that said, frenuloplasty. So basically you're going to reshape, especially the tongue and then obviously the lip as well, where you're probably placing stitches and all that type of stuff or sutures. So you're reshaping it, you're excising it. And then I've been in the room when they do Z-plasties, but I usually just close the flap, a different way like this definition says. So in the course, we teach it both ways. I was trained way back when, 2015, I think is when I did my first frenectomy. And we did it in the operating room. I did a lot of them in the operating room with the old traditional way where you basically just need 2 straight mosquitoes. You can kind of see those in the center off to the right, a 15 blade, and then a 3 or 4 chromic gut suture on a non-cutting needle, and then obviously some local. And did they achieve absolute maximum relief? Not necessarily, but they absolutely got symptomatic relief. And it's just a, good, better, best. And this is a really good, if not better way of going through life after this procedure. And then the best is with the light scalpel or the laser, right? I've moved to that, but that doesn't mean you have to. So I like to teach it both ways. Not everyone can buy a $40,000, $50,000 laser, or you just have it sitting around doing nothing because you wouldn't buy it otherwise. So that's what we teach in the course. And you'll see a case where we did it. One of the mentees doesn't have a laser, doesn't have an opportunity to get one, I think, as an associate. And so he really was just interested in the old traditional way. And we got a great result on that patient who was super symptomatic. So, so you can see here before, during, and after. Let's see. So we schedule an hour for what we do before we get to. Well, you look like you want to say something.
No, I'm just.
So it takes about an hour is our consult. Now, if we're seeing an infant, everything pretty much we're within that hour where we get the referral. They've already done all the intake, everything on the front end. So we can really speed along and make sure that parents are very focused and they know what they do because they're providing almost 100% of the post-op care and stretching. So that's one subset. We're developing that course and hopefully 2027 is when we'll launch that. So the children will mainly focus on. So we have moved to basically doing a consult first.
For our clinic.
For our clinic.
And I will digress. Like Michael works in, we have our own specialty clinic within this space, but seen it integrated into regular dental practice. So I think like hygiene is definitely a great way to start this within a dental practice of like navigating that. And then as a practice, y'all can kind of determine who your collaborative care is. But typically what we do is a pre-op consult exam with our children and adults. We usually get our referrals in, we assess everything, confirm diagnoses. If they're working with another provider, they're traditionally doing some sort of pre-op exercising and tongue posture. They might be doing physical therapy, adjustments, body work, things like that. And then the procedure itself is honestly like less than the procedure is literally super fast, even with our adults and children. It's just kiddos, you're really just setting and getting them comfortable. Same with a lot of adults who are a little bit unsettled or nervous. You're working on a muscle. It's just slightly different, but still you're in the mouth. And so we actually use popsicles in our clinic for all ages because it is amenable.
Well, everyone loves this taste of it, local anesthetic. And so, you know, so we give them popsicles. That helps kind of calm the nerves.
And then afterwards, in regards to patient experience, it's twofold. So are they going to be working with somebody afterwards? It really just depends. We work, one of our clinics is more rural. And so we are really just meeting the patients where they're at and trying to provide optimal results in the best case scenario for them. So sometimes it's just literally doing the releases for them, talking through post-op work for them to do at home, which is exercises and stretching. But post-operatively, a lot of patients, especially adults, you're looking at about 2 to 4 weeks of additional tightness. So sometimes people feel like they're actually more tight after the procedure. Very, very normal. And then you're looking at progression and relief of symptoms over a 2 to 6 month window. They are being sent home with exercises of the tongue. And they are also being sent home with stretching, and it's super integral because it's going to help with mobility. It's going to help with tension relief, as well as it's going to prevent reattachment of the tissue. When we're suturing, you definitely have a much better outcome, but especially in our infant population, we're not as much.
We're not suturing at all.
Yeah, we're worried about that fresh tissue reattaching to itself. But from a post-op standpoint, it is a bit of a journey. Like you're kind of like a step one in this process. You get that relief. You can do some follow-up care. We like to do it every like 2 and 4 weeks just to keep track of patients. And then we'll do probably something about 2 to 3 months. And then at around 6 months, we do have patients send us pictures as well, but it just kind of lets us get eyes on the wound post-operatively. It heals a little bit differently than some other areas. It's still in the oral cavity. But functionality wise, it's just a different added element that isn't always put with procedures. So having that range of motion and stretching and exercising is super important. And there's some other aspects too. And then also from a pain standpoint, most younger kids, they're bouncing back right away like usual. When we're in, our teenagers and adults, we're typically seeing some discomfort within the first week. You are kind of having soft food diet. The tongue fatigues easily. You might have some difficulty talking the first 48 hours, just more from inflammation and fatigue and soreness. And then for adults, same thing, about 5 to 7 days of soreness. And we're working with just, ibuprofen, Tylenol. There's other options out there as well.
We started to do topical lidocaine, like viscous lidocaine.
To help with stretching.
That actually works really well. Pre-stretching, same with some serapeptase. But
and then serapeptase is another thing that we introduce after a certain point as well.
Yeah. So, case. This is a 28-year-old male with a history of lisp, speech and language difficulties. He knew he was tied. He told me. He actually, I think this picture was taken when we were about to take his wisdom teeth out in the wisdom tooth course that we also teach at CSI. And I said, yes, you are. And I don't have my instruments here. I don't have a laser. I tried digging some stuff up just to give him symptomatic relief, because he checked pretty much every box that we have in our assessment. But I didn't even have that, just because we weren't there for this. This was like a couple of years ago. So picky eating, choking on spit, liquids, difficulty brushing. Could not bring the tip of his tongue. I mean, that's as high as he could get it. You can see the whole floor of his mouth is raised up, and it's really, he's having to work overtime. And then you can kind of see side view, right? I mean, we've all seen stuff like this, but then what do you do? Well, you're functioning just fine. Or is he, right? And he wasn't. He was so ready to get it done. He would do whatever. He would do it without local anesthetic. That's how desperate he was. Now, he was there for the wisdom teeth, so we addressed that. But, so you can kind of see post-op after on the left. He's able to lateralize. I don't have a pre-op photo of him lateralizing, but he's able to lateralize and actually sweep the tip of his tongue all the way to the posterior of 15 and 2, because I know he has the wisdom teeth out because we took him out. And then and then you can see how much elevation, massive elevation that he got post-operatively. Now we sutured it. This was the old traditional way. This was from the course in April, actually. I saw him, a year and a half later, finally, we're like, is he going to be part of the course? Because, it's just been so long. And so finally we got to take care of him, and he post-operatively was able to get so much more elevation, and he started crying as soon as we were done and placed the last stitch in. So this is without the laser. You can get an absolute great result with this and symptomatic relief. And he had instant symptomatic relief, right? He's able to speak better, even though he was numb. He's able to move his tongue where he had never been able to move it. And I forget the rest of the history of his case, but it was just a pretty profound case, like we see so often after post-operatively. So, and then, yeah, you can before and after, right? So that's a pretty significant gift to give somebody after being tethered for so long, and like I said, he started crying. He's actually happy. Like, I'm looking at the picture and I'm like, he was.
That's him super happy.
Yeah, you can see the crew that we had there, the mentees, and so
that's Jeremy.
He's the one that didn't have the laser and wanted to do it traditional way. And I'm like, right on. Like, that's why I want to teach that, because I know that skill set. I know what it takes to do it. And honestly, it's see one, do one, teach one. And that's how we learn in residency. And that's the gift I want to give, in this way and the laser procedural way. So next, we have a 22-year-old female with speech and language difficulties. Tongue catches on the lower front teeth. You can see that they're pretty severely tied. And then some orthodontic issues. A few pre-op photos. And I think you all have access to this PowerPoint. So you can look at.
Breeze through them a little bit.
Yep. So you can see that tension. I really wanted to point out the white blanching right above the or right in the middle of the right picture. If you're looking at your screen, you can see that blanching with me just elevating, and then the whole floor of her mouth is raised up, and it's not separate. So you can see the blanching as well in the lower left. And then the beauty, now this is a laser case, the beauty with that is it's a pretty bloodless surgery. I mean, to the old traditional technique that I had done is not a bloodless surgery. It's, some type of tissue scissors where they cut, they can't see because everything's bleeding. And then, they try to close it as best they can. It takes a lot longer. Then you have the other traditional technique where you use 2 straight mosquitoes. You basically ride along the lower border of the caruncles and all the way to the base of the tongue, and then clamp that off, and then ride the other one above it. You raise it up to the base of the tongue, and then you excise that tissue in between because it's a V. Well, that's awesome. So that's the last case. So case 2 is actually laser. So you can kind of see on the right there that we have a little bit of bleeding, but you can see everything. And in surgery, if you can see, you can do. And that's why I love the 2 techniques. So you can see on the left, a little closer up, and then you can see the floor of the mouth. I'm basically holding it down and how much elevation she's able to get. So that's a beautiful thing. And then we do place stitches. So again, this is the laser. You can see I probably would place one more stitch right here, right under that. But outside of that, everything looks beautiful. So now we have a 10-year-old male with a history of breastfeeding difficulties. Tongue was clipped in the hospital. We have 7 frena in our mouth. He was tied on both maxillary buccal and labial, and then tongue. And then mastoid pain, bilateral, were very significant tension, and then head and neck muscle tension. You can kind of see the mixed dentition. And so the maxillary frenum, you can see the blanching with retraction of lip. Diastema may or may not be affected at this point. I mean, should it be there? Should it not? I think it's too early to tell in his case, but you can see the frenum on the buccal here is all the way inserted into the alveolar crest, which is not typical. Usually it's mucosa. And so you can see Eiffel Tower, tent, thick base, fibrous, pink, blanched, pink towards the lip and blanched. And then, sorry about that. Let's see. And then on retraction, you can kind of see that on the left picture. And then tongue. Tongue, you can kind of see heart-shaped blanching in the middle, floor of mouth elevation, same on the left. So this is a case that we did under laser frenectomy, and you can see night and day difference. So that's pre-op on the left. That's as high as you can possibly get it. And then on the right, that's about 10 months post-op. So beautiful extension of tongue. The floor of mouth is a little raised, but nothing like it was previously. And then you can kind of see side view, and then he can open as wide as possible, and basically the tip of his tongue, which is a grade 1 on the scale that we have, goes all the way to the lower or the upper incisors. So here's a maneuver that if you come through the course, we can teach you, but basically it's the palatal suction, and then now he doesn't have any overflow. So his tongue is pretty much not overflowing onto the molars. So that means it has plenty of space. And then these pictures are not so good. I'm not sure what happened, but you can see the buccal frenum and the maxillary.
Right after the release.
This is right after the release. So massive.
Or like a few weeks after.
Yeah, massive difference there. All right. So let's talk, numbers, revenue. The average procedure fee is between $500 and $1,200 ish. Some areas it might be more, some areas it might be less, but I think that kind of captures that in a nutshell. The average case, so infants, we have it pretty much dialed into an hour. One appointment where we're doing everything same day. The children and adults, it's usually a consult for us. Now, and we'll talk about kind of how to integrate this into your practice, and it basically incorporates, the periodic and the comp exam. But this is just like the next step, and then we'll take a step back. So it's about an hour and a half. So if it's just a consult for child and adult, it's about an hour. We get some really good photos. We get them familiar with us, take pictures of our stuff for the kids so they know, I manage a lot of autistic patients. I'm like, take pictures of whatever you need. It really helps them. It helps with the kids get familiar with us, because up to around at age 11, we're really not giving local. We're just doing it under the best topical ever, which is
case by case,
right? We did a couple 3-year-olds last week, I forget. But those are tough cases. Those are some of the toughest, like a 1-year-old to 3 years old are some of the toughest cases. But, we did them, and we did them in the outside of the OR, outside of anesthesia, general anesthesia, and then with topical anesthetic. Beautiful results. So the surgery for children is about an hour, maybe less.
And that's just the appointment, the appointment time total. Honestly, it's more just, to actually do the laser portion of the procedure is about 5 minutes on the younger kids, give or take. You take breaks. Adults, you're looking about 5 to 10 15 minutes potentially.
Yep. You got to blunt dissect, and you're looking at the different structures, and then you're functionally assessing it with both. So the procedure itself doesn't take that long. It's more the lead up and then the after,
and it can be. I mean, like a 30-minute. I mean, realistically, 30 minutes to an hour with consult and procedure for older children and adults, and then you could add probably a little bit of time for follow-ups, but. Case-wise, kind of building that opportunity.
So yeah, cases 5 per month, 25 to 6,000. Now that's per site. That's not the whole kit and caboodle. It's per site. It depends, right?
Yeah.
So I know some people, like we used to charge $550 for everything.
Yeah.
Then we moved up to around 1,000 for everything, just because in our area. But it depends on how many people are doing in your area. Are other people taking insurance? We take medical insurance. That's a unique thing. We don't take any dental. We're uncredentialed with all medical, and that's a interesting thing. So
we'll talk about that in a second.
Yeah. So that 20 cases per month. I mean, 10 to 20K per procedure, right? So if you're doing a lip, you might charge a little bit less than a tongue, although insurance has it flip flop. So coding and billing, we have a slide that kind of shares all of this type of stuff. And then the coding billing mistakes. But yeah, here's a slide that basically breaks it down. The infant, the otomy is really like we're excising tissue. We're vaporizing tissue. So in my book, it's a frenectomy, but insurances think otherwise, because a frenectomy is where you're actually excising tissue, like we do with the 2 straight mosquitoes and the scalpel and then the laser. But anyway, and then the plasties is children, like older children to teenagers to adults, because they've been tethered for so long.
So are you saying they're going to downgrade that to an otomy, or
some insurances take so the 40819, like Blue Cross Shield doesn't accept for an infant, but like Aetna does. I don't know. Bethany's
the medical billing aspect of it. So I definitely think the medical, if you can do medical, if you're going to see babies, medical billing is the way to do it.
Mm-hmm.
And each insurance determines things that are out of scope of medical practice, which is its own beast. So like one of the insurances won't let us do the frenectomies, even though that's what the procedure is, that's what the language of that code is. They've made their own rules of what falls under what. So even our older children patients, we're usually doing like those CPT codes specifically. But dental, like
they'll accept it because there is no otomy.
Yeah, well, but dental is more like cut and dry with that kind of verbiage and so forth. So
if I know a lot of tongue tie centers across the country just do fee for service because they just don't want to mess around with this.
Because the truth is like we have seen that some of the dental insurances don't accept a frenectomy or frenotomy or frenuloplasty. I mean, most of them do, but some of them have like completely dropped it with babies specifically. That's why we went into medical billing for majority of the procedures for our little clinic. And then it's controversial across the board, and there's some very fine rules around it. Some of the dental insurances have dropped it. Some of them have it. Some of them are only medical. So it's kind of navigating your area and understanding. We do know that fee for service is very common in this space. And if you can win your referral provider network along those lines, like that's really the way to really do it and support it if you can.
But if you do build dental, I mean, when we build in the hospital, we build all those as dental and they were all covered.
Yeah.
And I'm sure they had the negotiated rate. So if you are in network and you do frenectomies, the D79, 61 and 62 cover most of what you're going to do. And then in children and then in the adults to teenage, like you're going to be doing the plasty, which is a much higher level.
Mm-hmm.
So you can, $1,200, that's actually a pretty good rate, I think, for frenuloplasty because it's so much more technique sensitive and involved. And if you come to the course, that just help you gain that skill set. and then you're able to utilize it. And so you can charge the D7963 because you are blunt dissecting, you're, staying safe, because the blood vessels, the nerve, scary thing if you don't know how to manage it, but we teach you all that. And again, see one, do one, teach one. And I wholeheartedly believe that. So
Awesome.
yeah. So your referral network, I mean, it can be yourself. Like, how do you integrate this into your practice? It could be you catch them, and then you do the consult. Basically, you're in a periodic exam. You say, hey, I got a new skill set, a new training level, and I'm evaluating for this now because it's part of the airway, and I really, value the rest of you, not just your teeth. And you're not throwing any other dentists under the bus, because any dental schools. You're just saying, hey, they didn't really train us in this. This is the new lens I'm looking at it through. So I'm just going, if you're in a periodic and they're asking, why are you just catching this now? And that's kind of the communication step that you can give them to be able to just bridge that, right? And then, they already probably have a splint because they're bruxing. All the other, they might be snoring. They might have already have a CPAP, and now you're catching it and you're saying, hey, I think we can help with this. Let's schedule some time so we can actually talk about it. So that's your consult from periodic to the chair. And you schedule maybe 30 to 60 minutes, or you might have a sec to go. I know I've talked through this with other general dentists, like how would you integrate this and then practice it. And that's what we would do, is you kind of do a consult right then and there. So you get them out of your hygienist chair and don't tie that up. And then you might have a minute or two or 20 minutes or so to kind of do a workup. And we give you all that as part of the course, and going through the Ferris 6 and Ferris 6 plus 10 or Ferris 6 plus 4, which is basically an airway assessment. And then you can also become, your IBCLCs, your speech language pathologist, your myofunctional therapist. Even pediatric dentists refer to us because they don't want to mess with it, because they don't either have the laser or just they're so busy with other stuff, or midwife. So that's the ring of trust and that you can get as far as a referral base. So this is us at Tongue Point in the Olympic National Mountains. That's our whole family, and so.
Tongue point.
Real quick, Dr. Dienberg, we have a question. It says, if you don't use the laser and you get bleeding, do you warn them before that they could get bleeding for, say, several days afterwards?
Yeah, I mean, that's always part of the risk, right? We say minimal to no bleeding.
With the laser.
With the laser. And then I also say minimal to no bleeding with the technique I was trained on and teach, because you are clamping the capillary bed with that hemostat. It's a small straight hemostat, which is very skinny, and it gets in there and it gets out of your way of excising is the most amount of tissue. And then you're suturing it. You're basically running a continuous from the tip or wherever the top portion is all the way to the base of the tongue and floor of mouth intersection, and then out from the base of the tongue to right above the caruncles or the sublingual ducts. And so it's sutured and they don't get much bleeding. But if they do, yeah, I mean, they have to manage it. And so hopefully that answered that question.
Thank you.
Yep.
So getting this into your practice, your 90-day journey.
Take the course, get your hands on real experience. Equipment decisions, I mean, we can go through all that. You saw the basic surgery setup for doing it without a laser. And those things are really, it's just when I couldn't do it with a third molar, it was the 2 straight mosquitoes. Everyone has scalpels and pretty much that whole setup. So it's just, and those 2 straight mosquitoes are, I want to say like less than $10, if I remember buying them within the last few years. Team education. This is a team-based procedure because it does involve, coordinating and all that type of stuff, and then consents and post-op documentation. So here's an infant. You don't see teeth. So let's see. IBCLCs. Are you going to be your main?
Starting to see it in practice, getting your team on board was first step. Integrating it, identifying it. starting your referral network of providers, or starting to get some folks on hand in your clinic potentially if you're bringing in an OMT, or getting going with your own team if somebody's interested in that and supporting that. And then advertising and mentioning it as a added service to your clinic.
Yep.
How many oral myofascial therapists are there in a community typically?
It depends on
It
the
really,
state.
yeah, it depends on your location and the education and stuff. So
We have one, for instance, we live an hour and 15 minutes away from Portland through a mountain range next to the Columbia River. We're kind of rural. We have one out by us that's practicing. Now in Portland, there's probably 100.
There's so many, but there also, you can do oral myofunctional therapy virtually.
Mm-hmm.
It's really nice to have hands-on, but there are a lot of them who do it virtually, and they do accept insurance, which is also a heavy hitter for some patients. They're like, I can't afford that. Maybe it's a barrier to entry. Yeah. And so we also try not to put that restriction fully, but if it's something that you could bring in. So are there a lot? It is growing. It's been around for a while, but it is definitely more, you're seeing it kind of grow and grow. We are seeing some hygiene, and we've heard of quite a few who've left practices to go do this instead of hygiene. Yep. So seeing it as an opportunity to reel that back in
or
potentially.
Do both.
Yeah, or do both. Yeah, we've got some who are doing both too.
Yeah.
There's a lot of practices who have like speech and language pathology who also have oral myofunctional therapy in-house too. But I think you're definitely seeing it more in the bigger cities. A lot of options. You want somebody who's going to coordinate care with you, and not tell you what to do, or kind of make it pigeonhole you into certain situations when you're trying to find them. But it's becoming more common, but it's still, I feel like, is like, even when we come into like Portland and Vancouver, it's not as common. We see it growing out here.
Yeah.
And we know that it's being educated in this space a lot right now.
Yep. And then execute and refine. So month 3, you're getting in there, your first cases with confidence, collecting the feedback, and then building your network referral, building your case base, so you can show and tell. And then you can circle back with us, because we're going to help, guide you. And that's one of the beautiful things with CSI is being able to communicate with us, and we can help you through cases after the course. So 3 things to remember for today is the patient is already there. They're in your practice. There's so many that go undiagnosed, untreated. And if you just ask a few questions, prompt the hygienist to just have like a pool of like 10 questions that they can probe and just ask without like selling, that is one of the strongest things I've found to be able to have a conversation and to explore it a little bit more. And then also put it in your diagnosis, in your comp exam, like, ankyloglossia, yes or no, right? Or lip tie. And then building a referral network, because there's plenty of people that we've found looking for someone that does this to a high degree level, that gets good results. And so if you can get that, then it really helps even grow that. And you might find that you really like doing this surgery and, pretty much specializing in just that, right? But the one action you can take is identify 3 patients in your practice today. Even, what day is it? Wednesday, before the end of the week. And whether it's a tongue and or lip tie, what are you doing to assess that? I mean, one of the beautiful things you can do is basically take your index finger, gloved, place it above the lingual frenum, and then have the patient elevate their tongue and just see if you have any tension there. You'll find that the patients that have no tension, that's not a tongue tie. You find that patients that have tongue cupping in the middle portion, and all you're doing is just holding it there. You're not trying to like press their floor down. You're just holding it where it should be, and then letting their tongue do the work. Just try that and see what type of resistance you get. And you can kind of incorporate that into grabbing the tongue with the 2x2 and checking for the tongue cancer on a lateral border. So.
And then, yeah, we're having course in September. We're working with, older kid patients and adults right now. We're hoping to introduce infants in the next year. We do feel that infants are really straightforward, and when you can introduce them into your practice, it just is more nuanced in terms of course-wise, as well as you really need to have a really collaborative onboard team. Your assistants really, you have, like, you're working with babies and postpartum mamas and parents.
Yeah.
So there's definitely some different conversations and language to be used and to handle and work with those patients specifically, because they're in a different space than our general population postpartum as well. And then working with the babies and understanding how to hold them. So that's something we really want to introduce. There's a lot of power there. And honestly, once you can get those procedures, they're very straightforward and productive.
The infant procedures are pretty, it's the easiest. I mean, it's just all the other stuff that you have to unpack and be able to do, good, or be good at doing. And that's where we want to be able to kind of bridge that gap. So you'll have to take this course first, get efficient in this, and then
qualify for the next.
Yeah. But this course is coming up in September, and it's still open. I know it's coming quick. It's closing quick. But outside of that,
and it's hands-on experience.
Yes, actually, that's one of the major things. It's the only hands-on course in the whole country that you are doing the surgery for this frenectomy, especially linguals, right? You might have already done a lip tie already. Those are fairly straightforward. The tongue, a lot of people are scared of, and we want to unpack that and show you it's not that scary. It's really pretty easy once you get the hang of it. And yeah, there's risk associated with it, but it's the only hands-on course. All other courses, to my knowledge at this point, are basically observational, where you're looking over the shoulder. You are not tactically doing the surgery. You might feel for a portion, or it's like an online course where you're kind of walking through the stuff. So this is, you are doing the surgery. We do maybe a demo case or two, but other than that, yeah. So
awesome. That was awesome, you guys. Bethany, are you going to give any tips, or can people pull you aside and talk about medical billing and how you were able to integrate that?
Yeah, absolutely. I'm very open to it. It's been a joyride. Honestly, we just got a biller, but there is some special nuances to getting that credentialing. Michael actually one who really, he just plowed his way in. But it
a lot
is
of phone calls.
I definitely can talk about it, because there are way more nuances when you have a 2-week-old baby who hasn't been added to insurance and all of these other things for approval. So,
and dentists you can be credentialed. Oral surgeons do it all the time, and that's a taxonomy we use, but you can be credentialed with medical and dental. We choose to just do medical, but you can do both.
Yeah.
And so.
Absolutely.
Great. Thank you. I appreciate that.
And then there's some starter pack thing for giveaway today with a referral pad.
Yeah.
Kind of get your own logo and stuff on there.
And then
thank you. Yeah.
That's it. Make sure you guys, if you guys are interested in going, it's September 12th and 13th. Just go to coloradosurgicalinstitute.com. Use the coupon code SNIP15. It's not a vasectomy course. This is a frenectomy course. SNIP15, and it'll get you a little bit of a discount there. Thank you guys so much. What a great informational presentation that was. I really appreciate your time, and it was very well organized and made perfect sense. The way that you guys walked through it, and I've seen these guys in action. It is actually quite spectacular. You guys are going to want to see this for yourself, and it's a great way to open up your clinical suite to just a portion of your patient base that you hadn't thought about in the past. And then in the future, once you get comfortable with the procedure, you can open up to those referral sources and really make it a true profit center like you guys broke down. So really, really great stuff.
For sure. Yeah.
Awesome.
Our
Thank
pleasure.
you for having us.
Yeah.
All right, everybody. Thank you guys so much. That concludes our webinar for today. We really appreciate you showing up. There's quite a few of you guys that were live, and thank you for posting questions. And for those of you that are catching this on recording, welcome, and thank you for joining as well. Thanks, guys. Have a great day, and we'll talk to you soon.